Good afternoon, everyone, and welcome to Grand Rounds. We have a great speaker and topic for today. Dr. Safi has prepared an excellent lecture, so I'm so glad that you could join us and participate. I wanted to remind everyone that is listening via Teams, please make sure that you mute yourselves when you join us. Don't hit mute all because then you mute the speaker, and we have had that happen. So just make sure that you mute yourself. At the end, when Dr. Safi is ready for Q&A, questions and answers, go ahead and unmute yourself then. That way, we can hear your question right away. The problem with chat is sometimes we don't always get to it right away. So if you can just kind of go ahead and holler out or, just go ahead and ask your questions, we can answer it in a timely manner. All right, so I'm going to turn it over to the introduction, and then from there, we will start with your grand rounds. So thanks again, everyone.
Good afternoon. Dr. Safi, as you know him, is the chief of sleep medicine. He's been with us since September last year. And want to say a few things about him. He went to medical school in Erbil in Jordan, which is probably about 40 miles away from River Jordan. Reportedly, Jesus Christ was baptized around there. And but then after medical school, he did a residency over there in Jordan. Then after that came to Michigan, where he did his residency in pediatrics, followed by a fellowship in pulmonary medicine. And then after that, he went to Madison, Wisconsin to do another fellowship in pediatric sleep medicine. So as you all know, there's a big crossover between pulmonary medicine and sleep medicine. So he's the right person to talk to us about the interplay between these two disorders, particularly what happened to respiratory physiology during sleeping children, who of course are not miniature adults. So Dr. Safi, over to you.
Thank you.
Thanks for coming. Yeah.
Thanks, Sam, and good afternoon, everyone. So today we'll talk about the differences in the pathophysiology of pulmonary and sleep disorders between the children and adults. And I have nothing to disclose today. So there is a continuous process of change in anatomy and change in physiology in the body with growth. And that's what we call growth and development. And this includes every single system in the body. And the sleep physiology itself as well, it changes with age. So if you look at the upper airway development and the lung development, there are major differences between the adult airways and the pediatric airways. So for example, the larynx in infants and young toddlers is usually located at higher level, usually C3, C4, compared to adults' larynx, which is at the level of C4, C5. And what that means is because of the larynx is at higher level, the tongue is pushed up, causing more narrowing in the upper airways compared to the adult airways. The other thing is the larynx is more exposed to irritants from outward, such as, like, for example, in patients who have aspiration, or from inside the body, such as in patients who have reflux. The other difference is the size of the tongue is in proportion to the oral cavity is relatively large. And this can result in more narrowing in the upper airways. And for that reason, like most young infants, they are obligate nasal breathers, meaning that obstruction at the level of the nose can be as significant as obstruction anywhere else in the airways. For example, patients with bilateral choanal atresia, they can present with cardiopulmonary arrest just from the nasal obstruction itself because they cannot use their mouth to breathe at all. Very important thing to keep in mind, for example, is young newborns or young infants who need an NG tube for feeding. Because if you do that, you already took away 50% of their capacity of breathing because they cannot use their mouth to breathe. And on top of that, because the NG tube goes all the way down to the stomach, that can result in the lower esophageal sphincter to be open, which means that they are more likely to have acid reflux, which can irritate this area and cause more obstruction, besides impaired ability to breathe from their nose. And this can result in significant gas exchange abnormalities. So that's why sometimes when we order a sleep study in a newborn, we request that if we can remove the NG tube, that will give us a better idea about what's going on. Now, the shape of the airways is also different. So in adults, it's more like a cylindrical tube, while in pediatrics, it's more like a funnel, especially in infants and young toddlers. So the size of, or the narrowest portion in the airways in infants and young toddlers is at the level of the cricoid, which means that any degree of inflammation, subglottic inflammation, can result in significant obstruction and significant respiratory distress. Unlike in adults, even if they have some degree of inflammation, because the airways are already large, there is larger diameter, you do not see as much gas exchange abnormalities and respiratory distress. One other change is the occiput itself. In infants and young toddlers, it is more prominent, meaning if they sleep in a supine position, their head tends to be flexed, and that can cause more narrowing in the airways. This is a study that was done looking at the volume of the airways, mainly the upper airways in children and adults. Now, there are many studies done on this topic, but I did choose this study, although it has only 5 patients, is because the age groups. So we have 10 days old, 7 months old, 3 years, 5 years, and one adult 53-year-old. And because of they have good images that give us an idea about how the airway anatomy changes with time. So what they did is they did a 3D CT scan, and they created a model of the upper airway, looking at the volume of the airways. So if you look here, so what you see is that the size of the airways or the diameter of the airway increased significantly with age. So that's one change. The other thing that you will see is that the airway volume itself, it increases with age. So from a 10-day-old, it's like 3.5 cubic centimeters, while in an adult, it's close to 50 or above 50. So you see that there's a huge change in the volume of the upper airways with age. Now, if you look here, you see that the cross-sectional area as well, which is an indirect measure of the diameter or radius of the airways, also increased significantly with age. And that increase from the more proximal airways to the more distal airways is more significant in adults compared to pediatric age groups. Now, there's an exception here. So if you look here, so you see these 2 exceptions in which the volume of the airways is smaller. And you can see it here in this model that they created. And this, in fact, is due to the soft tissue growth, mainly the tonsils and the adenoids, that is usually seen happening at very high rates and between the age of 3 to 5 years. And that coincides with the higher prevalence of obstructive sleep apnea in these patients or in these children. I think this is shown a lot, especially when we talk about asthma, but the same principles apply to upper airways as well. So we know that the resistance is inversely proportional to the radius to the 4th power. This means that if you have an infant airway, whether it's upper or lower, that is, let's say, 4 millimeters in diameter, and there's an edema of only 2 millimeters, that will result in reduction of the diameter by 50%. However, the airflow resistance increased by 16 folds. That's a significant increase. While in an adult who have, let's say, 8 millimeter airway with the 2 millimeter edema, the reduction in the diameter is only 25%, and the increase in resistance is only 3 folds. So you see the huge difference in increased airflow resistance with minimal inflammation in children compared to adults because of their smaller airways. Now, lung development continues until adolescence. So what happened is around birth, it is estimated that the lungs have around 100 million alveolar spaces. This is in a full-term infants. Now, as they get older, through a process called alveolarization, the number of these alveolar spaces will increase. And around the age of 8 years, the number is around 500 million. So although this is a 5-fold increase in alveolar spaces, but the surface area available for gas exchange, it increased 20 times. So you can imagine that you have 20 times more capabilities for gas exchange, extracting oxygen from air and washing out CO2 from the body. And that can explain also why we see significant gas exchange abnormalities, even with minor illnesses, respiratory tract illnesses in younger age groups. One other thing that is really important is the difference in airway mechanics and chest wall mechanics between children and adults. So the way that we breathe is like the intercostal muscles will contract, so the ribs will move more horizontally. The diaphragm also will contract and will move downward. So this will create more space inside the chest. This will create a vacuum, and so the air will move from the area of higher pressure, which is the atmospheric air, to the area of the lower pressure, which is the intrathoracic cavity. This is how we breathe. And when we exhale, what will happen is the relaxation of these muscles. So you have less space and you have more like relatively higher pressure inside the chest compared to outside, then the air will move outward. Now, there is a problem with this in infants and young toddlers. And the reason for that is because the ribs are already more horizontal, meaning that they lose this mechanical advantage. So their ventilatory pump is less efficient in young children and in toddlers compared to adults. And again, that's another reason why it's easier for them to develop gas exchange abnormalities and hypoventilation, even with minor disease processes compared to adults. Now, this is like pure physiology. So the equilibrium point for the respiratory system is a point called FRC, the functional residual capacity. Is how much air is inside the lungs when air is not moving in or out, when the epiglottis is open or the glottis is open. So at FRC, which is the equilibrium point, the inward pull caused by the lung recoil equals the outward pull caused by the chest wall recoil. Now, infants' lung recoil is almost equal to that of an adult. However, their chest wall compliance is 2 to 3 times higher in the first 2 to 3 years of life, meaning that the inward pull is much higher than the outward pull. And which means that at equilibrium, kids breathe at a relatively lower FRC. And why this is important? It's because we know that there's strong correlation between the lung volume and upper airway collapsibility. Many studies were done in adults and kids, and this is an example of a study done in adults, showing that patients who have chronic lung disease and they have lower lung volumes, what happens that their apnea-hypopnea index is higher because the upper airways are more collapsible. They tend more to obstruct during sleep and with illnesses. One other important difference between adult lungs and pediatric lungs is collateral ventilation. So generally speaking, there are different ways for the air to get into the alveolar spaces. So you have the main passage, okay, which is the respiratory bronchioles. It gets down to the alveolar spaces. Now, if you do not have this collateral ventilation, if you have obstruction here, this alveolar space will collapse and does not participate in gas exchange at all. And we know that in infants and in kids up to the age of 3 or 4 years, these collateral ventilations, they are not very well developed, meaning that if you have obstruction here, this area will collapse. In older age groups, they still have this like alternative ways for the air to reach to the alveolar space, and it continue to contribute to ventilation and gas exchange. Now, one important difference also is that the metabolic rates in infants and children is much higher than in adults. That explains why the younger age groups, they have higher
metabolic rate.
Could you please mute yourself?
Mm-hmm.
So the metabolic rate is higher in infants and children, and that explains why they have higher respiratory rate and higher heart rate. This is mainly for many reasons, but the two major reasons is they have higher energy demands and they have higher energy or heat loss. So I'll start with the second one. So some cells, they have up to 2,000 mitochondria, which is a source for heat, meaning that these cells can reach to a temperature as high as 50 Celsius. However, the physiologic body temperature is close to 37. So how we lose this extra heat, there are many methods for that, but the major one is via the body surface. And we know from physics that if you have a sphere that doubles in radius, the surface area will increase 4 folds. However, the volume will increase 8 folds. It means that the volume is much higher than the surface area increase. Although our body does not follow the same geometry, but it follows the same rules of physics. And this is explained by this. So, like if you look at the ratio between surface area and body mass or body volume, you see it's very high in newborns, and it decreases as the child gets older, and it's much lower, almost less than half in an adult. So, so what that means that these patients here, or these like individuals who are newborns and younger age groups, they have higher surface area. So in order to maintain a normal physiologic temperature, they need a higher metabolic rate to maintain that. So they need to produce more heat because much of that heat is going to be lost. And there is higher energy demand, and the main reason for that is to support the growth and development. So, for example, the head circumference, it increased by around 12 centimeters in the first year of life, and that's a lot. Then only 2 or 3 centimeters a year in the second year, then around 1 centimeter per year after that until the age of 5 to 6. Then the rate of increase is much lower than that. Now the brain volume, as this head circumference increase, will increase significantly from 350, and it becomes very close to the adult volume around this age, 5 to 6 years. In order for that to happen, in order to support normal development and the growth of the brain, you need enough calories and you need enough oxygen. And for that, the minute ventilation is much higher. The other aspects here is that the weight doubles by the age of 4 months, then it triples by the age of 1 year, then it quadruples at the age of 2 years. So you see there's much growth early in life. The height or length, it doubles around the age of 4 years. So what that tells us is because there's really high demand for energy to support this growth, the minute ventilation will be really high. So as you see here, below the age of 1 year, it's close to 600 liters per kilogram per kilogram of body weight per day. And in adults, it's almost 1/3 of that, because now they do not need to support this much growth anymore. And that's another reason, like when we treat children who have sleep apnea or hypoxia when they're younger, sometimes we are not sure if the patient needs oxygen or not. We usually try to be on the safe side because, again, oxygen is needed for brain development in the first 2 to 3 years of life. So, and if you miss that golden window to support normal growth, the damage might be irreversible. So usually when we're in doubt, we go with oxygen therapy rather than not treating with oxygen. I will not talk about sleep and insomnia in this talk, and I promise that there will be another presentation for that. But an easy way to remember how much sleep kids need. So now, generally speaking, around the age of 10 years, they need around 10 hours of sleep, plus minus 1 hour. Now, if when children are 1 year younger, then they need approximately 1 hour more. So that's 11 hours. If they are like 5 years older, then they need 1 year less. So it's 10 plus 1 minus 1. This is an easy way to remember how much sleep kids need. And this is the mean value. So you can say plus minus 1 hour. And this does not apply for kids who have developmental delays. So autistic patients, they do not sleep that much. They can function at much lower need for sleep than this. Another thing to remember is the naps. So around the age of 3 years, approximately 50% of children, they stop napping. Meaning if I have a toddler coming to my clinic, like a 3 or a 4-year-old, and who's have very poor sleep at night, and they're still napping, the first logical thing to do is try to decrease the frequency or the duration of the naps, or eliminate the naps completely, to see if that is going to improve the daytime sleep. Unfortunately, we live in an era in which everyone looking for a shortcut, which is unfortunately medications, before even considering eliminating the naps in these kids. So, and in fact, both the American Academy of Pediatrics and American Academy of Sleep Medicine recommend against using sleep aids in children with insomnia. Now, this is what we call a sleep hypnogram. So what you see here is like how the sleep, what stages of sleep we have at night. So this is wake. These are like lighter stage of sleep, and this is deep sleep. The thick lines here represent rapid eye movement sleep. Now, during rapid eye movement sleep, there is a condition called diaphragmatic fragmentation, meaning that the innervation of the diaphragm become very irregular. So the contractions are not very well coordinated. You see irregular breathing during REM sleep, which will result in decreased lung volume. You can see more gas exchange abnormalities during REM sleep. And REM sleep tend to happen mostly in the second half of the night, not the first half of the night. That's a reason why if you depend only on symptoms to diagnose sleep disordered breathing, such as obstructive sleep apnea, you might miss a lot of patients because they do not have that much sleep early in the night, and you might not observe any of the symptoms associated with upper airway obstruction. Now, when we come to how we define hypoxia, and this is still debatable until now. So in the past, there were many definitions for it, and each one or each center adopted a different definition. Now, for example, the International Classification of Sleep Disorder, 3rd edition, and the text revision that was released like a few months ago, they still adopt this definition, which is not very accurate. So it says in pediatrics, the oxygen saturation 90% or below for at least 5 minutes during sleep. When hypoventilation is not documented. If hypoventilation is documented, then you do not call this hypoxemia anymore. This is hypoventilation, and the diagnostic and therapeutic approach will be completely different. Now, because of the debate that was there, because why this is important? Because this does not specify age groups. So for example, if you have a child who's like 1 year old who sleeps for 16 hours per night, and then you have a child who's 10 years old who sleeps for 10 hours per night. So it doesn't make sense that you still use only 5 minutes to diagnose hypoxia in both age groups. There's a huge difference in their body physiology. So you cannot depend on this definition. So this definition is inaccurate. So the American Thoracic Society, they tried to overcome this. So they published their clinical practice guidelines for oxygen therapy and how to define hypoxia. And this applies for patients while they're awake or asleep. So it's not just for nocturnal hypoxia. And again, although this is a big review, like systematic search in like almost 2,000 articles, still it has its own limitations. Now, generally speaking, what we say is if someone has oxygen levels at 90 or less for at least 5% of total sleep time, then this qualifies for nocturnal hypoxia, if this is happening during sleep. Or you need at least 3 different measurements at different times that are equal or less than 90%. It doesn't mean that they have to happen like back to back, like on the same day. You need to have them at different times, because if a patient's sick and you have these measurements, does not qualify them to be diagnosed with the chronic hypoxia that need to be treated. It might be acute hypoxia from underlying disease that is going on, acute process. But again, this is not accurate for more than one, like it is the best that we have, but it's still not very accurate. Now, we as pulmonologists and sleep providers, sometimes we deviate from this definition, but this is based on our understanding of the pulmonary physiology and how it changes with age and how it's different from one disease process to another. Now, when it comes to hypoventilation, and I'll show you like the huge difference between how we define hypoventilation in an adult and a child. So in adults, what you need is a CO2 level more than 55 for at least 10 minutes, or it increased by 10 points to above 50 for at least 10 minutes. Meaning that if an adult patient starts the night with CO2 level at 41, and then it increases throughout the night, and by the end of the night, they had 10 minutes with CO2 levels above, let's say 52, so that's 10 points more, then this is enough to diagnose them with hypoventilation. Now in children, you need them to spend 25% of total sleep time with CO2 level above 50. So that's in a 10-year-old who sleeps for 10 hours, that's 2.5 hours. While here, it's only 10 minutes. So you see the huge difference. There's a huge difference. And the big question here, where do you draw that line? Where do you say I'm gonna follow the adult criteria or the pediatric criteria? So for example, if you have a 12-year-old in your clinic who has big size, who you think their lungs reach their max, mostly mature, would you follow the adult criteria or pediatric criteria? So that's still vague. No one knows. Now, if you have same thing when it comes to sleep apnea severity, because when you look at the severity, for example, in adults, in order to consider severe, it needs to be more than 30 apneic events or apnea-hypopnea per 1 hour sleep. In pediatrics, it needs only to be above 10. So where you draw that line and say, okay, I'll deal with this as an adult patient or as a pediatric patient. This is a vague area. So for me, for example, if I have someone coming to my clinic, a 16-year-old boy, and he already has a beard, start to be like you can see it, then for sure I'm gonna follow the adult criteria. If I have a 16-year-old girl who's already on oral contraceptive pills, for sure I'm gonna use the adult criteria, not the pediatric criteria. So we do not go with the legal definition of being an adult or children. You need to use your clinical judgment as well. Now, how did we come with these references for pediatrics? So for example, let's take an example for the hypoventilation, the high CO2 level, because of that huge difference between adult and pediatrics. So the way that we come with most of our values, whether they're normal or abnormal, they study number of patients, then they do statistical analysis, then you get that normal distribution curve, you define the mean, and then you define standard deviations. If 2 standard deviation above the mean, this is how you define it's abnormally high. 2 standard deviation below the mean, this is how you define it's abnormally low. So what they did is this study was done in more than 500 patients in different sleep centers. It was done in 2006, and most of the values that we use right now is derived from this study. Now, one notice is this was done at sea level or very close to sea level, meaning that when the breathing physiology changes with changing in altitude, those criteria might not apply. And that's again why pulmonologists and sleep providers should use their clinical judgment sometimes and not blindly follow the guidelines as they are. So if you look at the end-tidal, so when they tested the patients, one thing they looked at is end-tidal CO2. So they found that the average or the mean was close to 40. Standard deviation is 4.5. So if you take 2 standard deviation above 40, it's almost 50. So they rounded up that number to 50. So above 50 is abnormal. This is how they decided that 50 is abnormal. How they decided it's 25% of the time. Again, they looked at the time they spent above 50, which we already decided it's abnormal. They found that the mean was 2.8 and the standard deviation 11.3. If you add 2 standard deviation to this number and you round it up, it will be 25%. So this is how they came up with these numbers. However, one big limitation of the study, besides that it was done at sea level, is it was done for patients age group between 3 years. The youngest, I think, was 3 years, 7 months. And the oldest was almost 8.5 years, meaning that's almost 3 to 8 years. That is the range. Now, we know from everything that we discussed earlier that the physiology is significantly different in infants and toddlers below the age of 3 years, meaning that those might not apply. And again, those, we're using the same criteria still for that younger age group in which they were not studied. Same thing for kids who are older than the age of 8.5 years. We're still using the same criteria, but does this really apply? Unfortunately, we do not have any other studies to support what we need to do and how to define normal and abnormal. And this is, again, another reason why pulmonologists should use their clinical sense and clinical judgment when they treat these patients. Now, when we talk about sleep apnea, so there are major differences in the phenotype of sleep apnea between adults and pediatrics. Now, the peak age in kids is somewhere between 2 to 8, with the peak really is between 3 to 5, to be honest with you, not this. And in adults, it's usually above the age of 50. That's the peak age when it's diagnosed. Now, male to female ratio is almost the same, but as they get older, above the age of 13, due to the sexual maturation, it becomes closer to the adult phenotype, so it becomes more frequent in males. The most common cause for obstruction is tonsillar hypertrophy and adenoid hypertrophy. That's why the first-line treatment that is recommended is removing the tonsils and the adenoids. While in adults, it's more because of obesity. Now, obstructive sleep apnea is one cause for failure to thrive. So if you have an infant who has failure to thrive and you could not find the cause, one thing that you need to screen for is sleep apnea, because they might be spending all this energy trying to breathe because they have significant upper airway obstruction. And that can result in failure to thrive. So once you treat the sleep apnea, you see that they start to gain weight and they start to grow normally. In adults, most patients are obese. In fact, studies show that maybe more than 70% of adults who have sleep apnea are obese. Now, excessive daytime sleepiness is not a common feature in children. In fact, most kids with sleep apnea, they present with hyperactivity, aggressive behavior, rather than inattention, ADHD-like symptoms, rather than presenting with daytime sleepiness. Now, the way that we define it is also different. The obstruction is different. Now, obstructive hypoventilation, and I will come to that in a second, is a feature that you see in children. You do not see it that much in adults. So how we diagnose sleep apnea? So we do a sleep study. This is the gold standard for diagnosis. And then you need symptoms plus abnormal AHI. Now, we do an overnight sleep study. And in adults, you have a high AHI with symptoms, then you diagnose sleep apnea. Let's see. So what is sleep apnea? What is obstructive sleep apnea? So this is what we look at when we read a sleep study. There are many signals. Those are a few of them. So we look at the nasal pressure signal. We look at the oronasal thermal flow. So those are flow signals from the upper airways. And then we monitor the chest wall contraction and the abdominal wall contraction. So what we see is there's decrease in airflow from the upper airways while the respiratory efforts continue. It means that the body is trying to overcome this obstruction by continue to breathe. And sometimes you see paradoxical breathing or you see increased respiratory effort. Now, if you see this, it means that there is degree of airflow resistance. Now, in order to say this is sleep apnea, we need this to be associated either with drop in oxygen by at least 3 points, or, which is not shown here, is change in brain activity in the EEG, which we call arousal. If you see all of this, then you call this obstructive apnea or obstructive hypopnea. Now, what we do, we count how many of those happen throughout the night, then we divide that number by how many hours of sleep the patient had. And that will give us an index called obstructive apnea hypopnea index. And if it's more than 1, for example, in pediatrics, then this is obstructive sleep apnea. In adults, it needs to be now with the new text revision, it has to be more than 15. In the past, it was more than 5. And I think we might witness in the next few years that they might change the definition for pediatrics as well. Now, in pediatrics, so it's almost the same. So you need symptoms and you need an AHI above 1, which we decided is the cutoff between normal and abnormal. But an important feature that you do not see in adults and is in pediatrics is this. It's called obstructive hypoventilation. So in which there is 25% of total sleep time spent with oxygen level above 50. This is an example for obstructive hypoventilation. And we sometimes we argue a lot with our colleagues from ENT about if this sleep apnea or not, because what they look at is the apnea hypopnea index. So they say, well, the apnea hypopnea index was normal, but it can be normal in patients with obstructive hypoventilation. The apnea hypopnea index can literally be 0, and you have obstructive hypoventilation, and this is a criteria to diagnose obstructive sleep apnea. So what you see here, this is the brain activity. You see the snoring with each breath. You can see that there is flattening in the airflow. And what you see here is there's paradoxical movement. So it means that there's increased respiratory efforts. The oxygen levels is 93. You do not see any dips. You do not see any arousals to label any of these events as obstructive apnea or hypopnea. But you see here, the CO2 level is high. So in this example, the patient had more than 30% of total sleep time with CO2 level above 50. So this is obstructive hypoventilation. This is obstructive sleep apnea, despite the normal AHI, and the treatment is the same. The first-line treatment is adenotonsillectomy. This is a very interesting study that was published like in 2019 by Dr. Dept, who was one of our colleagues working here. So what he did is, because we always Like we always say that you cannot have a normal sleep study in a newborn. Whenever you do a sleep study in a newborn, it's always abnormal based on the criteria that we use today. So what he decided to do, he said, okay, let me study this population. Let me study full-term newborns between the age of gestation age 37 to 42 weeks who are healthy, who are ready to go home, okay? And he studied them between the age of, I think, 1 day to 30 days. So none of them were older than 30 days. And what he found was really interesting. So the mean apnea hypopnea index was almost 15. So based on the criteria, those are healthy newborns. They were ready to go home. Okay, so there's nothing. Or they were brought back from home to do the sleep study. So based on the criteria that we use right now, this is severe sleep apnea. So this make you wonder, are we really treating these patients the way that they should be treated? If we like, because again, we never, and maybe Dr. Jujamini will agree with me, we never did a sleep study in a newborn, and we did read, I would say, hundreds and hundreds of studies in newborns. It's always abnormal. Is it really abnormal, or is it their body physiology is different? So we need to use a different criteria to diagnose sleep apnea for this age group. And again, it's not black or white. You always need to use your clinical judgment. Now, the other thing that you see here is we have obstructive and we have central. So usually in most, if you look at the way that we score sleep studies, when it comes to hypopnea, it's really difficult to differentiate between central hypopnea and obstructive hypopnea in young infants and in newborns. Usually, by definition, they are scored all as obstructive, but in reality, most of these might be really central. So if you add this number to this number, most likely there's some obstructive component, but most of these are central. So why is that? It's because of everything that we discussed earlier in this talk about the physiology. It's totally different. And two is because their breathing centers are not mature yet. Even in a full term, the breathing centers are not mature yet. It takes some time for them to know how to control the breathing. So one other important thing to understand is something called the apneic threshold. It's the threshold at which central sleep apnea might develop. Those what are called hypocarbic central sleep apneas. So you see that, like if someone has, like in an adult, let's say that their threshold is at 40, usually their baseline CO2 is somewhere like 44, 45. Meaning that even with increased respiratory effort, they might not wash out CO2 that it drops below the apneic thresholds. Now, in newborns, it's very close to their apneic threshold. Their baseline CO2 sits only 1 to 2 points away from their apneic threshold, meaning that when they have increased respiratory effort due to upper airway obstruction or airflow limitation, they can wash out CO2 very quickly, and they drop below the apneic threshold, and you start seeing central sleep apneas. Now, what about treatment? So treatment in adults is different than treatment in pediatrics in general. So this is example for how we treat adult sleep apnea. So adenotensiluctomy is not listed here. So adenotensiluctomy is not useful to treat sleep apnea in adults. The best that it can do, it can maybe like improve the snoring or resolve the snoring. Other than that, it doesn't do anything else. While in pediatrics, the vast majority of cases is due to adenotonsillar hypertrophy, and that's why the treatment of choice is TNA or tonsillectomy and adenoidectomy. Now, and there's a very important thing here. There is no correlation between the size of the tonsils and the presence or absence of sleep apnea. There is no correlation between the size of the tonsils and the severity of the sleep apnea. People think that in order to diagnose, in order to qualify for the treatment, the tonsils need to be large. If they're small, then it's not a treatment. And that's, the research shows us different story. It's not the case. You can have really small tonsils causing significant degree of obstruction, because again, it's everything that we discussed earlier, everything interacts, the upper airway collapsibility. On top of that narrowing from even small tonsils, that narrowing become really significant. So removing the tonsils can result in significant improvement in airflow, and it can help with the sleep apnea. If not treating it completely, it can reduce the severity significantly and improve the symptoms. Now, we have an epidemic of childhood obesity, unfortunately, and we see more and more of these children who are obese. So now we see more of that adult phenotype of sleep apnea, in which still the adenotonsillectomy is the first line, but it might become less effective than in other patients who are not obese. Now, in some cases, if they still have residual sleep apnea and some symptoms, then a combination or a treatment with nasal steroid and Montelukast can help with these patients. Now, we do not do split night studies, meaning that we start with a diagnostic study, and if we find out that the patient already have sleep apnea in the first few hours, then we start CPAP therapy. The reason for that is because, like, if you do this and the child is not desensitized to use the mask and the machine, they get very worried, they get frightened, and good luck, you know, trying to start CPAP therapy for them later. They will refuse it. So it will become more difficult to use this treatment. That's why American Academy of Pediatrics and American Academy of Sleep Medicine recommend against doing split night studies in children. Now, another thing is that BAP adherence, like positive airway pressure therapy adherence, such as CPAP or BiPAP, it's not dependent on the patient's developmental delays or the patient age. In fact, it depends more on parents' involvement. And this is very important. I have, in my own experience, I have a lot of patients who under foster care who cannot use the CPAP. They changed the foster family, and within a week, they were perfect users. So that tells you, that confirms this finding. And this is based also on a lot of research. What about oxygen therapy? Oxygen therapy is a good treatment for sleep apnea? So oxygen is not a recommended treatment for sleep apnea per se. However, sometimes it's the only option. Now, we cannot use, for example, CPAP therapy for a 2-year-old who does not qualify for adenotonsillectomy due to the high risk for complications. The reason for that, again, if you remember that the growth of the head is very significant in the first 2 years of life. So if you use a mask on their face, you need to have a good seal. It needs to be really tight. So what will happen? Their head will grow, but their face is not growing, which will result in mid-facial hypoplasia, which by itself is can cause irreversible obstruction in the upper airways that is more difficult to treat. Now we are talking about major surgery, like maxillofacial surgery, to fix that. So that's why CPAP therapy is almost never used to treat sleep apnea in infants and young toddlers. So instead, we use oxygen. And again, because we know that the body physiology and the airway dynamics, upper and lower, the mechanics, everything improves with aging. So they might outgrow their sleep apnea just by buying them some time. So what we do is we start them on oxygen therapy just to make sure that they get enough oxygen that they need because of their high metabolic demand until they outgrow the sleep apnea. So I'll go, I don't think that we have enough time, but I'll go over this very quickly. So because Down syndrome is a major risk factor for obstructive sleep apnea. There are many studies done looking at the prevalence of sleep apnea in patients with Down syndrome that were done in the past decade. So like this is a big meta-analysis that included almost 1,200 children. Mean age is close to 8 years. And they found that like the vast majority of these kids, they have moderate to severe obstructive sleep apnea, especially when they're younger. Another study done on that, looking at 33 children with Down syndrome who have snoring, mean age 5 years, none had adenotonsillectomy, 90% were not obese, and all reported snoring. So the prevalence of sleep apnea in this group, if you snore, what the study is telling you, if you have a Down syndrome patient who snores, there is 97% chance that they have sleep apnea. And most likely it is severe sleep apnea. So this is how common sleep apnea in children with Down syndrome. One other thing, this is another study, for example, 22 patients, mean age 11 years, non-adenotonsillectomy. Now, snoring was reported only in 1/3 of all these patients. Snoring was reported in almost 40% of patients who have sleep apnea. So 60% of patients who have sleep apnea that we know from statistics most likely to be severe did not even report snoring. Another study done, like 50% of Down syndrome patients with sleep apnea do not report symptoms. This is a different study. And also another study suggests that symptoms do not predict the presence or absence of obstructive sleep apnea by sleep study in this population, which is patients with Down syndrome. That's why the American Academy of Pediatrics adopted this recommendation that all kids with Down syndrome should be screened with a sleep study by the age of 4 years, even regardless to the symptoms, even if they do not report any symptoms. And this, in fact, may apply for older age groups as well, based on the other studies that we just showed. Now, what is the treatment? Now, treatment is adenotonsillectomy. Overall success rate for adenotonsillectomy in all kids with sleep apnea is close to 80%. This is really high. Even on the 20% who do not in which the adenotensioculum does not cure the sleep apnea, it still can decrease the severity of the sleep apnea. Now, in patients with Down syndrome, residual sleep apnea is seen in a lot of them. Again, it might be much milder, meaning that you can observe. But even with that, because there's 50% reduction in the severity, so that's why it's still recommended as a first-line treatment, even in patients with Down syndrome. Now, what about CPAP therapy? So, in fact, the interesting finding, based on many studies done on this topic, that the adherence of patients with Down syndrome is much higher than the adherence to CPAP therapy than the adherence of patients who do not have Down syndrome. Probably because maybe the parents will be more involved with everything going on. They might be more involved in making sure that they get the treatment that they need. So 2/3 found to still using the therapy at 12 months, and around 80% based on another study using it more than 4 hours per night, 1 to 3 years after starting the therapy. Thank you. Any questions? Okay, I'm working on preparing another talk about insomnia, hopefully in the near future. And in that talk, I'll be talking about how we define normal and abnormal sleep. And I will talk in depth about using medications in treating insomnia. I think we are guilty as physicians that we have extremely low threshold in prescribing medications to treat insomnia, which is not the best way in treating this condition. So, and hopefully in the near future, I will be able to give a presentation about that topic. And thank you, everyone.
Did anyone on Teams have any questions? I guess not. I thought maybe somebody. I thought maybe some people on Teams.
Oh,
Because they always tell me later
I know.
that they type it,
Yeah.
but we don't see it right away.
Oh, okay. I see. Okay, good. Thanks, Susan.
Oh, well, thank you so much. That was good. I mean, I'm not a doctor, but it was Thank you.
Thank you.
Bye, Sam.
Bye, how are you?